afternoon, everyone. Today's webinar is Treating Pediatric Neuromuscular Disorders. The Future is Now. We're really happy to have the authors of this paper here 5 years later to talk about their reflections and thoughts around the treatment landscape for neuromuscular disorders. We'll go ahead and stop sharing the screen here. Go ahead and introduce our speakers today. Dr. Craig Campbell is the Chair of Pediatrics Research, the Head of Division of Pediatric Neurology, and the Medical Director of the Multidisciplinary Neuromuscular Clinic at Children's Centre in London, and the Pediatric Neurophysiology Laboratory at Children's Hospital London Health Sciences Centre. He is a full professor in pediatrics, clinical neurological sciences, and epidemiology at Western University, and a scientist at Children's Health Research Institute. Dr. Campbell has led and leads many clinical trials for neuromuscular disorders and is an investigator with the Neuromuscular Disease Network for Canada. We also have here Dr. Dowling. Dr. Jim Dowling is a professor of pediatrics and molecular genetics at the University of Toronto and a neurologist and senior scientist at the Hospital for Sick Children. He leads a translational research program focusing on the diagnosis and treatment of pediatric NMDs with a focus on congenital myopathies and muscular dystrophies. Dr. Dowling has published more than 100 peer-reviewed manuscripts on topics related to NMDs. Dr. Dowling is also an investigator of the Neuromuscular Disease Network for Canada and serves on the steering committee. We also have Dr. Ronald Cohen, who is the president and CEO of the Hospital for Sick Children in Toronto, and he's been the CEO since May 1st of 2019. Dr. Cohen had joined Sick Kids in 2012 as a chief of the Division of Clinical and Metabolic Genetics, co-director of the Center for Genetic Medicine, and a senior scientist at the Sick Kids Research Institute. Dr. Cohen's laboratory focuses on the biology of muscle regeneration as it relates to various inherited and acquired myopathic states with the particular interest in muscular dystrophies. So thank you all so much for joining today's panel. And really, I had asked, we don't necessarily need slides. Through our research hotline in the past, we've had our research hotline for the past 2 years, and this paper often comes up. Families, clients have shared this paper with us and said, how close are we to these predictions, or where are these clinical trials at, and what's the update? And so really wanted to have an open conversation with all of you. And so I thought we would start on a positive note. As I was looking back at the paper, particularly in the spinal muscular atrophy section, I wanted to ask all of you, what are your impressions and thoughts on that SMA section? How much has changed in terms of the treatment landscape for spinal muscular atrophy in the past 5 years alone? Dr. Campbell, can I ask you to start off with your thoughts there?
Well, thanks, Humir, and thanks everyone for joining us today. It's great to share the panel with Jim and Ronnie, who are really, such amazing colleagues, but giants in the field and have been pioneers in so many ways. So it's really exciting for me to be here and kind of revisit that adventure. We went on to try and do a very comprehensive review of emerging therapies in neuromuscular disease. So thanks for sort of bringing us back to reflect. I mean, the first thing that comes to mind is really for SMA, how like what a transformative time for SMA. I mean, it's very rare that I think back to when I started in this career 20 years ago. Did I ever imagine that there'd be a disease that we really utterly transformed the natural history so significantly? And I would never imagine that. But that's really where we are with SMA. With the treatments, we talked about gene therapy and about antisense therapy and about small molecule therapy in the paper, but to see them now really all clinically available and clinically available largely across the span of SMA, and then to see that combined with advances in newborn screening, such that we can get treatments to patients at that critical time before there's degeneration of the motor neuron, and hence their muscle. I mean, this really is got to be one of the most major advances in any area of medicine for a long time. Granted, for a small number of people, SMA is a rare disease, but the impact seems remarkable to me.
Dr. Cohen, what are your impressions around treatment landscape for SMA? Anything else to add there?
First of all, I want to support every single word that Craig just mentioned. I think we're actually about the same age, so we probably started our early career at the similar age. And I remember actually my third day as a resident in Germany, admitting a child with SMA type 1 and having an end-of-life discussion with the family, because we obviously didn't have any really therapeutic options available. So I think it cannot be understated what Greg just said in terms of, we love to use the word transformative, but that's a really good example of using the word transformative. And and I do think it opens the window into opportunities for many other diseases. I think Greg briefly spoke about the importance of newborn screening. I think one of the questions we will ask ourselves, when I say we, it's really the medical field in general, with so many therapeutic developments for so many disorders. One of the questions we will be somewhat struggling with or trying to find out is, what is the therapeutic window for our children that we are treating? When is it potentially too late to treat? And SMA is a very good example where the combination of newborn screening and a very powerful therapy being available early on underscores what we pediatricians always say when we talk about every day in the life of a child matters. And it's probably not more true than it is for the SMA babies. So I think if I look back at my career, that is probably so far one of the most transformative therapeutic advances I have ever witnessed.
Thank you, Dr. Cohen. Dr. Dallin.
Not much more to add in agreeing about the transformative nature of the therapy. And I'm just looking at the article itself and the amazing aspect to reflect that all of the SMA drugs were in clinical trials still when we wrote the article. So, there is probably not rapid, but pretty quick development of the therapies over the past couple of years. And I think that reflects well on the global neuromuscular community, the patient family groups as well. I think there's just been contributions across the board to make these therapies move forward. I think what's interesting to think about is something Craig mentioned about transforming the natural history. And I anticipate SMA being the sort of leading neuromuscular disease in that regard, as well, as we learn now that we have therapy, what does a disease look like? Are we going to now, it's a new condition, essentially. And what will that mean in terms of how we consider treatment moving forward and management of patients moving forward? Are we going to be discovering new elements of the condition that we didn't appreciate before because the children were so severely affected by their motor neuron disease? And also, I think we're going to learn really important lessons about how we may combine therapies and what that can look like, and how we try to understand, in the era of expensive medicines as well, how do we think about that rationally? What is the pathway forward? And I anticipate, as 5 years from now, we're going to be talking about a whole new group of lessons that we've learned from SMA because of this. So I think exciting, amazing time, but also looking forward to all the things that are yet to happen.
Wonderful. Actually, my next question is something that has already been mentioned. It was around the therapeutic window. In the paper, you talk about the therapeutic window and SMA. And then there was also a question here around newborn screening. So perhaps I can extend this to say, are there other neuromuscular disorders that would benefit from this therapeutic window or from newborn screening that were mentioned in the article, other genetic NMDs.
Maybe, oh, are you going to start, Ryan? I was going to say, I have an obvious candidate, and I think, and maybe what Ronnie was going to say, which is DMD. You know, one of the amazing and I think, I guess, unfortunate truths is that even though we've known how to diagnose DMD for many, many years, the diagnostic gap remains. I think there was a paper in Muscle and Nerve last year showing that the 2-year gap in the age of diagnosis has essentially remained unchanged over the past 20 years. And that puts patients with DMD at a therapeutic disadvantage because we're seeing the patients and diagnosing them when they already have significant muscle involvement. And I really wonder if one of the reasons why all of the therapies that have thus far moved through through clinical trials have had relatively modest impact is because we're treating patients who already have advanced disease in terms of the molecular nature of their muscles. And I believe we're going to find out that if we can treat patients with DMD earlier, that we're going to see more of a robust therapeutic effect, and that we're missing an important therapeutic window in that condition because of the age of diagnosis.
Yeah, so I agree with everything that Jim said, and I think DMD is a very good example for another progressive disease. I do, and while I think all of this is true, don't misunderstand me. I do think, though, we need to focus our attention also on the older children and provide them with opportunities of clinical trials. And I say that for 2 reasons. Number one, while for the last 30 years probably, particularly as it relates to Duchenne muscular dystrophy, we have been under the assumption there is significant scientific evidence that the more muscle mass you lose, and where muscle is replaced by fat and scar tissue, you're most likely not going to be able to restore some of the muscle mass. There is no full scientific proof to this hypothesis, though. Some of our I call them grand muscle scientists from 20, 30 years ago, or have been talking about what the environment, the cellular environment around scar tissue is, and whether there's something that could be reprogrammed potentially. So while I don't want to create too much hope or so that some of this might be reversible, we actually don't know how older patients for many diseases, for sure for Duchenne muscular dystrophy, are going to respond to some of the treatments. So I think it's really important that we provide this generation of children and young adults also a chance for us to learn. And the second point I want to make, I have to say, maybe there have been a couple of humbling experiences in my professional life. And one was when, it was 8 years ago, I was in London at a patient conference around muscular dystrophies, and I had dinner with a group of 8 young men with Duchenne muscular dystrophy, and we were talking about different therapeutic options at that point. We were still in the developmental stages around clinical gene therapies, and all of these men told me, if you can just find a therapy to keep my hands moving and maybe some of my arms moving, that's all I need. And I have to admit, I'm not sure that I had recognized the different aspects and the different perspectives actually on the quality of life. So while I fully agree that the therapeutic window question for many, honestly, for even non-muscular disorders is going to be critical, we can't forget about the older children and young adults, and there's a lot to learn for us. as well as providing these children and young adults an opportunity that they should have as well.
I think that it's appreciated. I could say personally from the research hotline, oftentimes families will email and ask about clinical trial opportunities for boys that are older than the age of 12. And if opportunities are really limited to that age group of 5 to 8. And so I know that is wanted and encouraged. Before we move to DMD, there is one question that often comes through the hotline, which is in terms of SMA, sequential treatment. And so what I mean by that is families have talked about, accessing Spinraza, nusinersen, then they've received gene replacement therapy. And now we're looking to access risdiplam. So perhaps I can ask you, Dr. Campbell, what's our current state of knowledge around sequential therapies for SMA?
Yeah, that's a great question. And I mean, really, I think that will be, that will be the next, really pathway we have to understand better. That and I know we talked a lot about other non-genetic based or gene therapies in SMA, like myostatin inhibition and muscle contractile things and neuroprotectants, and so I mean, I think there's two things we need to understand. What are those other muscle modifiers or nerve modifiers, and will they make any benefit over and above now that we have a therapy that's more clearly disease modifying. To be honest, we don't have yet a lot of experience with sequential treatments. I mean, many of the clinicians in Canada have maybe been in scenarios where, for whatever reason, a child was able to get 2 therapies. Maybe they were in a clinical trial with one and then were eligible but really it's not that common yet. And certainly we don't have clinical trial data that really is what the foundation for us really making evidence-informed decisions about sequential therapies. So I think that's really important. But right now, most people in most parts of the world are going off, very limited experience with 1 or 2 families who may have gotten sequential therapies just by circumstance more than often by design, or in a way that can be really measured. So this will be important, and I hope our regulatory agencies and our as an investigator community and a patient community, we can advocate for those kind of clinical trials that ultimately give us the the best answer about how we treat people with SMA.
Excellent. Another question, as we look at the paper, there was a lot of mention around salbutamol, not just in terms of Duchenne muscular dystrophy, but other neuromuscular disorders. And so what is our current state of understanding of the use of salbutamol for different pediatric neuromuscular disorders? Dr. Dowling, can I ask you that one?
Yeah, it's a favorite topic of mine because we trial it in many of our patients, in part because it is extremely well tolerated, and so gives us an opportunity to intervene where there may not be other options. I think step back in part is to say, like, what do we think salbutamol does? I think the best evidence is that it is acting as a stabilizer and enhancer of the neuromuscular junction. So there's clear functionality related to improving NMJ signaling, and that's behind the rationale of using it in congenital myasthenic syndromes. And some of the congenital myasthenic syndromes are exquisitely salbutamol responsive, and in some cases it's a first-line agent. Dr. Lockmuller could probably talk most eloquently about that, and I think has in previous webinars. And then I suspect there's also some role for salbutamol in improving muscle contractility in a relatively non-specific way. And so that combination makes it so that there's the possibility that it can improve muscle performance across a lot of different conditions. There's a lot of anecdotal evidence for its role in SMA. And I think maybe Craig can correct me if I'm wrong, but there has been some consideration of pilot clinical trials of salbutamol that have shown a hint of efficacy. So I think that probably the strongest efficacy data exists related to type 2/3 SMA. We've seen some success with our congenital myopathy patients across multiple different genotypes in terms of qualitative improvements. And what we're trying to do now, and hopefully we're putting this experience together as a cohort, is look at when we've been trying to measure this objectively across several different conditions to see if we can get a better sense to which diseases may respond to salbutamol or which ones may not. And at present, if there's no contraindication and there's some at least biological rationale for trying it, we've been piloting it in most of our patients. So I think I'm pretty optimistic about using it, but it certainly isn't something that works across all conditions, and the impact of it is even in the best scenarios relatively modest, with the exception of some of the congenital myasthenic syndromes where truly it is a quite robust therapy.
Now, reflecting on the past 5 years in terms of Duchenne muscular dystrophy and the clinical trials that were mentioned in that section, and knowing that there are FDA-approved drugs for Duchenne muscular dystrophy, what are your thoughts and reflections around the treatment landscape for DMD? I'll ask you that first, Dr. Cohn.
Yeah, I'm happy to start, but I think we can probably all add to this. Look, in principle, the landscape for treatments for Duchenne muscular dystrophy has been improving and increasing over the last few years in a remarkable way. I mean, I think we have now at least 4 different gene therapy trials for microdystrophin that are actively ongoing. Some of the things we have learned here is that there's some immune-related problems that need to be dealt with. But at the same time, there are other non-gene therapy related therapies that are currently being trialed. There's one example that I think is worth emphasizing on. There's currently a drug out there in a stage 3 clinical trial called vamorolone, which was really initially discovered and developed as a potential substitute for steroid and prednisone therapy in having similar anti-inflammatory and other mechanistic impact on muscle that steroid has without some of the side effects. And it's a bit too early to say, but I will say that all the clinical trials so far are fairly promising, and I think if we meet again in 5 years, I wouldn't be surprised that that is now the standard of care treatment for patients with Duchenne muscular dystrophy. The other area of disease, of therapeutic avenues that obviously I'm personally a bit more invested in than many others, although Jim is doing research in this area too, is that I think our genome editing technologies that we started to first really dabble with about 9 years ago are constantly developing. And while we are still a little bit away from clinical trials here, I do think we'll see the first few clinical trials on genome editing therapies coming soon. And so I do think, obviously I wish, like all of the parents who are probably on this webinar, that things would go still even faster than they're going. At the same time, we need to make sure that what we are doing is safe, and if there are safety concerns, that we know how to address them. And maybe I leave one more last thought. Jim spoke about this earlier, I think, during his first comment around combinatorial therapies. For years, it was a concept that was actually almost kind of neglected by the neuromuscular community. I remember very vividly that 15 years ago, I was invited to an NIH workshop with a few people, and I actually spoke about it. And if people could have killed me, they would have killed me back then, of talking about the concept of muscle disease being complex diseases like cancer or HIV. It's a well-accepted concept that if you have cancer, you need to be treated with multiple different drugs and multiple different drugs to treat the side effects of the other drugs. Somehow, in many of the genetic communities that we live in, we always look for the golden bullet. And I think what Jim said earlier is something that we need to really emphasize over the next few years. As many different potentially promising therapies are developing, how are we going to start thinking about combining them and potentially having a complementary, even more potent effect on what we are seeing. So, but again, while we haven't reached maybe the stage of transformative change like in SMA, I do think we'll reach it. It's in reach now. That's how I would describe it.
What are your thoughts, Dr. Campbell, as you've led and participated in many clinical trials for drugs for DMD?
Yeah, well, I think to pick up on Dr. Cohen's comments there, it is exciting that this is, really actually one of the more active clinical trial spaces really in all of medicine. It's really remarkable, and I think that's because of the the cohesiveness of all the stakeholders. I mean, it really, I mean, one thing we're talking to folks today who are in the neuromuscular community and the DMD community, but it really does show the importance of of patients, patient organizations, clinicians, investigators, scientists, drug companies, all coming together with common purpose to and I firmly believe that's why the DMD drug development has been so so active. As Ronnie said, unfortunately, I think we wish for more in in the results of things, and sometimes it's maybe not so pleasant to talk about what we've learned sequentially from each trial, but we really have learned a lot from each trial, more about how to measure the outcomes in trials, more about the therapeutics. I mean, in fact, we wouldn't be in second generation exon skipping drugs if we didn't have the first generation of exon skipping drugs and realized that was suboptimal. So I think things build on each other, and well, it's slower than we want, and well, it means going through placebo-controlled clinical trials, and I think the movement, the commitment, and the knowledge now in the DMD community around around clinical trials is is really exciting, because I mean, things we talked about that transformative therapy in SMA, but the reality is in many areas drug development does take some time, and unfortunately there are clinical trials that don't that fail, for lack of a better word, that don't show the effect. There is lots exciting going on in DMD. Absolutely. I mean, really, to think back when I first started this work, and one of my first experiences as a brand new staff person coming in and doing a workshop was a family coming up and saying, "Oh, all we hear about is the newest thing in a mouse or or a rat." And now, really, families have opportunity to participate in clinical trials. There's often many choices. I mean, if you look at exon skipping, of exon skipping drugs for exon 51 amenable mutations, in fact, we've almost got so many clinical trials that it's problematic. There's, for such a small patient population with a rare disease. So these are things we're grappling with. They're good problems to have, frankly, in terms of realizing a treatment and ultimately a cure. But, it has laid bare some of the challenges with doing rare disease clinical trial work. And, I know we're all leaning into this to try and understand, how best to do that. But it's certainly an exciting time. And I see, positive momentum on almost every side, whether it be gene therapy, genetic-based therapies, muscle modifiers, steroid replacement. I mean, just to name a few.
Wonderful. There is, and I appreciate you answering part of a question that came up too, in terms of, in the paper, there were a number of clinical trials that were mentioned there, or companies that are no longer available or no longer active. But you did help to touch on the value of some of those first generation and the value of quote unquote failed clinical trials as well. There was also, and I think this is timely, there was mention that there would be ongoing studies and work in terms of looking at prednisone versus deflazacort. And so what is our current understanding around prednisone versus deflazacort? And then alongside that, there was mention around using deflazacort for other NMDs like limb-girdle muscular dystrophy. But perhaps, is there an updated understanding in terms of whether deflazacort provides better outcomes than prednisone for those with DMD?
Well, I can start there. So very recently, we've finished a very large clinical trial that was done in collaboration with many centers in many countries around the world. That was called the 4DMD trial. It was an NIH, primarily NIH sponsored trial that compared 3 treatment regimens of steroid, deflazacort and prednisone, and then 10 days on, 10 days off of prednisone. And that followed kids over a 3-year time frame. And so it's become clear to us through the results of that trial that in terms of the effect on muscle strength, now, again, these boys were early when they started the trial, so it's a little difficult to talk about some of those negative milestones like loss of ambulation. These were young boys started on steroid, but in terms of their ambulatory function, their speed of walking, their strength measurements, really prednisone and deflazacort performed quite equivalently in those motor outcomes. The alternate day steroids, not so much. And pretty much like we knew and recommend to most people, alternate days or reduced dose regimens of steroid is probably showing itself not to be nearly as effective. What we do consistently see, though, and even in the 4DMD trial, we do see that weight gain tends to be a little bit higher on prednisone. That's, of course, something that can be managed by good dietary things, so that side effect difference could be overcome. And when we look at other evidence around this, we do see that deflazacort tends to be better in multiple studies around weight gain. So I think people can feel confident to be on either of the 2 steroid regimens. In my in my opinion, I think the evidence suggests that there can be a comfort level around that. Of course, we all look for some promise for steroid sparing agents like vamorolone ultimately down the road. In terms of just quickly the comment around using it in other, limb girdles or Becker's muscular dystrophy or things like that. I mean, there certainly is an attraction to that in the sense that there, is muscle inflammation. But really, to my knowledge, there's not a lot of evidence for use. I think when we do that in the case of some of the later onset, more mild, for lack of a better term, muscular dystrophies, we're potentially doing that in situations where people are seeing their muscle function decline rapidly. They're worried, and we sometimes do that as a way to try and intervene, try and make a difference. But I will say, to my knowledge, there's not a lot of evidence to support that.
Thank you. Dr. Dowling, perhaps this is a question for you. What is, reflecting on the paper and thinking to our current state of understanding around Nemaline myopathy, how are we treating, or what's expected for treatment for Nemaline myopathy, particularly NEB22?
First, let me make just a follow-up comment to what Craig mentioned about the steroids and other MDs. I mean, I think there remains interest in understanding if other muscular dystrophies would respond. A priori, I think it's never made full sense to me why some of the others would not, particularly the dystroglycanopathies, where that sit at the hub where dystrophin is linked to the sarcolemmal membrane. So we've in a few anecdotal cases tried prednisone or deflazacort with some patients who have FKRP related muscular dystrophy, and seen some qualitative improvement, though I think there's been mixed results. And at one point there was a plan to do a clinical trial for FKRP. I think that, and maybe Ronnie, if you know, that was the University of Iowa was thinking of it. I think it never went anywhere. And I do believe there's still a planned trial for the congenital muscular dystrophy subtype of the LMNA related muscular dystrophy. I think reflecting on the sort of extensive inflammation seen in this patient biopsies as a motivation. But as to why it's sort of exquisitely useful in Duchenne and not in, for example, the dystroglycanopathies or the sarcoglycanopathies, I don't have a great explanation, but that seems to be the reality at this point. But yeah, so in terms of Nemaline, first I have to apologize because I don't often use the NEM nomenclature, and just as an editorial comment, that nomenclature is likely going away. There's some ongoing there's an international working group to revise the nomenclature for both limb-girdle muscular dystrophies and congenital muscular dystrophies, and I think we'll soon see a reflection of that. So NEM22, I have to be honest, is I don't know which gene that's referring to. Is it NEM2 maybe? Is that actually what is meant? Yeah, so NEM2 I think is Nebulin related Nemaline myopathy. So in general, there are no clearly effective therapies, unfortunately, for Nemaline. There was a case report study of L-tyrosine several years ago, which seems to potentially be helpful with secretions and oromotor function. Though my personal experience and in talking to several others who treat a lot of NM patients is that it's very modestly effective, and only in some cases. We've definitely tried salbutamol in several different individuals with both ACTA1 and NEB-related Nemaline myopathy. And I think for sure it's been safe, and potentially some modest effect as well, modest improvement. The broader question of where the therapeutic landscape sits, there's a relative paucity of therapies sort of in the pipeline, but I think that's rapidly changing. And I can potentially just give a little plug to our work. We have a couple different strategies that are in testing in the mouse model stage, which we're hopeful in the near future that we can, we'll see results sufficient to consider bringing to clinical trial. And I obviously want to acknowledge MD Canada, which helps support that work. I think equally as important, and this is true across many of the congenital muscle diseases, is that there's a current lack of natural history data. And I think as we, get hopeful about some preclinical candidates, it's equally important to think about the clinical trial readiness for the disease. There's a group of investigators that have been engaged with the patient community as well to talk about how we can move forward on defining disease natural history, particularly for NEB-related NM and ACTA1-related NM as a springboard for being ready for clinical trials when these therapies that are under consideration in preclinical models are ready. So I think that the current state is, unfortunately, no specific therapies at the moment, a few things potentially off-label, but with hope that that's going to change in the near future. and that we'll be equipped and ready to address that when the time comes.
Wonderful. A question for you, Dr. Fong. Families were really encouraged to see, I believe it was out of Sick Kids, there was a single patient gene therapy clinical trial, so an N of 1 study, and I think it was on SPG 50. And so the questions that we received around that is, and we didn't see that necessarily in the paper 5 years ago around more of those N of 1 clinical trials, but is that the way we're going with the potential in terms of single patient gene therapy clinical trials? And is there one currently for neuromuscular disorder?
So the answer to this is, I think it's going to be a way forward for many different conditions, and that will include neuromuscular conditions. And Jim really was the PI of the study, and it was a bit of a Herculean effort by many, many people to make this happen, including Health Canada, who has been a terrific collaborator here, which I think is really important to emphasize. We could not have done it without their collaboration. But in addition to the positive impact, obviously, on the child and the family, it has allowed us to create a framework of how do you run an N of 1 clinical trial, particularly as it relates to gene therapy or genome editing potential trial in the future. We know how to, we've had experience with N of 1 clinical trials in the oncology sphere, but it's very different when it comes to the gene therapy trial. So we have the system in place now. We will need a number of infrastructure in place to really scale this up, but at least we have it now in place, and there's no question that this is going to be part of the future, no question.
Another question that we often get is around stem cell therapies. And I feel like that kind of ebbs and flows. There's periods of time where we get more questions around this. And there used to be a lot of buzz around stem cell therapies for muscular dystrophies. And so now, however, we get more questions around gene therapies. What are your thoughts around stem cell therapies, gene therapies? Is there potential for these pediatric neuromuscular disorders to benefit from stem cell, or is gene therapies more promising?
I guess I can.
Sure.
I think there's a great potential to stem cell therapy, and the challenge is, it remains largely the same, which is how do you deliver sufficient number of stem cells that can then incorporate and reside within the muscle to help with muscle regeneration and repair, and also, as a strategy for a replacement or a treatment. I get the sense that there's some technologic advances that are happening that may make this more feasible, but I still think it's not ready for sort of quote unquote clinical prime time as a replacement therapy. If and when it gets worked out, it opens up a lot of really amazing potential, not just from the therapeutic benefit of the stem cells themselves, but you can imagine, if you draw, for example, the recent amazing study on sickle cell disease and beta thalassemia, where there was a CRISPR editing based approach as an ex vivo therapy. If once stem cell replacement it works, then you could potentially edit the cells and avoid a lot of the delivery problems that we're currently facing with muscle, both from the ability to get things to the muscle, but also the potential systemic toxicity associated with it. So I think it's a worthy thing to continue thinking about, and I know there's some very bright people that are trying to overcome the barriers, but I still see them, and I haven't seen anything yet that tells me that those barriers have been solved, but I'm hopeful that they will be, because I think that offers a lot of potential. I mean, I would put a small plug-in from the stem cell. If you think about stem cell therapy, not just as a cell therapy, but also the idea of activating or improving stem cell function, there's some advances that are underway now, and we know one of our great Canadian neuromuscular disease researchers, Mike Rudnicki, has shown some really promising results of modulating the stem cell compartment as a potential therapeutic for muscular dystrophy. And while that's not exactly cell therapy, it's an interesting, it's a allelic, a sort of a similar idea of improving the satellite cells as a way of repairing muscle.
And it comes back to the combinatorial therapy aspect that we've talked about, how these can complement each other in the future.
And maybe I'll make one small comment as a call to arms to our field of thinking about it. And Ronnie's comments have really made me think about this. Maybe we are now finally in the era where we need to be thinking outside the box and thinking about conditions like DMD the way that oncologists have been thinking about their diseases for years, and really developing more of a system where the ability to nimbly stratify patients and be able to offer different range of therapies and combinations of therapies is something we need to be proactive about thinking how we would do that. And certainly in Canada, we're so well set up to be thinking about that because of how well we all work together, and obviously the great collaboration with MD Canada and Jesse's Journey and other organizations that are really dedicated to neuromuscular treatment.
Yeah, that's an important, comment, Jim, because I think, there is opportunity and there's movement, even in the US around, this whole concept of platform clinical trials, or this idea of, making a standard of care pathway that really is involving new therapeutics and comparing them to current standard of therapy in a way that allows us to add some of these combinatorial or non-gene or genetic based therapies that might just change that margin of outcome a little bit, but measuring that in a very systematic way in every boy who has DMD might be a very effective way to figure out how we can absolutely fine tune and optimize all of this. The other comment I was just going to make, it's really interesting to see, especially with cell therapy, we've been so focused on delivering the cells and making sure they engraft, and that's been the focus. But there's some very very interesting work about the paracrine phenomena that happen with cell-based therapy, even the stimulation of growth factors, and those, even if the cells don't engraft fully. So that whole aspect will be very interesting to follow over the coming years in terms of how cell-based therapies actually alter the muscle milieu, if you will, the muscle environment ecosystem. So I think something to keep our eye on with a kind of a different way, slightly different way to think about cell therapies.
Shifting away from this question, but in the section on CMT in the paper, I believe there was a line that said there are limited therapeutic options for CMT, and so now 5 years later, Charcot-Marie-Tooth disease and neuropathy, what is the future of treating these childhood CMT looking like? And I know there's a question in the chat in terms of specifically for the ultra rare. So in this case, CMT4B3 is mentioned. Any changes since this paper was written around CMT treatment and management?
Maybe I can start.
Yeah, go ahead, Jim.
There are some. Actually, I think there's some traction in the ultra rare CMT space from a gene therapy perspective. So CMT4J, due to FIG4 mutations, there's preclinical data supporting gene replacement therapy, and there's very sort of active discussion about translating this now to the clinic for a clinical trial perspective. There's been some progress on gene therapy for CMTX, the connexin 32 gene therapy, and the CMT4B, MTMR2, which is 4B1, is amenable to, from a size perspective, for gene therapy. The CMT4B3, which is MTMR5, is, I think, too large to fit in AAV-based gene therapy, so may require an alternate approach. there is a really wonderful and active foundation now for CMT4B3 that's starting to support some preclinical studies with the hope of identifying new therapeutic strategies. So for example, we've been working with a zebrafish model of CMT4B3 as a hopeful springboard for identifying therapies. There's long been talk about a genetic approach to treating CMT1A, and specifically thinking about strategies that would lower PNP22 levels, and whether that's an RNAi-based approach. CRISPR would also be potentially a useful approach. And I know there's some people working on that. And I don't know when, but I'm pretty sure that there is some gene therapy, a genetic therapy related to knocking down PNP22, which is probably not too far down the road. There's going to be some really important challenges related to delivery, particularly for AAV, for peripheral neuropathy, for any of the CMTs. How do you do it? Is it systemic? Is it going to be intrathecal? Do you do a series of localized nerve injections? I think that systemic AAV isn't necessarily, may have some challenges in terms of fully getting to the nerves, and particularly for Schwann cell defects. So I think there's a lot that's being considered, but I'm not aware of any specific trial that is active at the moment. But I think for the CMT families and patients, stay tuned. I think importantly though, there's really good interface now with some of the CNT organizations and the networks in the US and some Canadian sites. So I think an important element to thinking about treatments coming is that we are involved in the treatments when they're ready for clinical trials. So at Sick Kids, for example, we're now one of the CMT centers of excellence, or at least that's sort of coming soon. And I think that hopefully will be a springboard to being involved in networked trials. And so keeping on top of that. I don't know if Ronnie or Craig, you have other comments about CMT from a therapy perspective.
I think you spoke about everything that I would have spoken about. So thank you.
Yeah, the only other thing I add, I mean, there is some, people have been asking a little bit about me about the PTX 3003, this combinatorial drug of baclofen, naltrexone, and sorbitol. This has I'm trying to, I think in the last year or 18 months, a randomized clinical trial did show a slowing of progression in CMT 1A with this compound. And so I will admit, I'm not sure where it is in the regulatory pathway of things, but I've been getting, certainly lots of questions about that. And I don't, but I don't know that there was Canadian participation in that trial, or that they've got Canada on their radar screen. But certainly something we have to look into as a neuromuscular community, and make sure we're advocating for this potentially as a accessible therapy for our families with CMT.
Wonderful. In the final 3 minutes, I wanted to give you each 1 minute to share, what are you hopeful about in terms of treating pediatric neuromuscular disorders? What are you looking forward to, or what is one prediction you have that you're hopeful will come true in the next 5 years? Dr. Cohn, can I start with you?
So I think we have already seen an unbelievable increase in opportunities for neuromuscular diseases over the last decade. And I am convinced that it's just going to increase somewhat expeditiously over the next 5 to 10 years. And we'll be learning so much over the next few years that I believe before I retire, the quality of life of patients with neuromuscular disorders, or at least many of them, will really be changed for the better. And I hope I have some time to go, but I'm not that young anymore. So.
Me next? Okay. I'm going to cheat and say multiple things. And I'll be more, I agree, I concur with Ronnie in terms of, I firmly believe we're going to see impact across multiple different neuromuscular patient groups. But specifically, I'm looking forward to seeing the first CRISPR trials for neuromuscular disorders and what the potential for what they may hold. I think that's been something that's been a couple of years now in the making, and I can't wait to see what those first trials look like. I think a prediction, not CRISPR related, but more ASO related, is that the big delivery problems that have really hindered the success of RNA therapeutics for muscle disease are going to be improved upon to the point that we're going to see much more meaningful exon skippers for DMD. And I think the first real robust therapeutics for myotonic dystrophy related to really targeting the toxic RNA. And then in my own area of the world, I'm very anxious to see where the gene therapy for myotubular myopathy ends up. It's really been a really pretty both exciting and sobering situation in terms of the efficacy, but also safety problems that have occurred with the clinical trial. And then you mentioned Nemaline myopathy, and I really am optimistic that we'll see the first therapeutic candidates emerge for Nemaline, for a disease that really has been without therapy up to now. So I stole a lot of things, sorry.
I mean, but isn't this the truth? I mean, that there's so much to be excited about, really. Gene therapies. I mean, we're making, obviously it has not been an easy road, but we're making, lots of headway there, understanding this better. I agree with Jim. The exon skipping and other antisense based RNA therapeutics are, just so exciting, and we're getting to a point where we're really seeing, some of those delivery things overcome, and really, the focus on rare disease. We touched here and there on it, but I think, there is a real intention around, understanding rare disease, study design for rare disease. I think our regulatory agencies and our governments are coming around to invest in rare disease. And so maybe just drawing back, I mean, that in and of itself, because we have a neuromuscular community that's so cohesive, that we have to have a shout out here to the families who go into these clinical trials, who enable the research, who entrust themselves to this process, and in fact, I mean, without them helping us to move this forward, this field would not be where it is. So I'm excited about the energy and the commitment from all the stakeholders. So thank you, everyone out there.
Thank you. That is exactly where we want to end today's webinar. It's really an exciting time, and I have to speak on behalf of MDC. We're so grateful to our generous donors, firefighters, families, clients who really help to support MDC so we can invest in transformative research and advocacy like what you just spoke about, Dr. Campbell. And we invite you all to continue to support MDC. We have our walk and roll events this spring and summer and into the fall, and we'd be happy for you all to join us and to continue to support researchers like yourselves. And thank you all so much for joining today's conversation and really helping to revisit this 5 years later. And we look forward to another conversation, hopefully not in 5 years, but very soon, to look at the changes in DMD and CMT and myotonic and changing the lives of those who are affected by pediatric neuromuscular disorders. So thank you all so much and have a great evening.
Thank you. Have a good night.
Thanks, everyone.